Heart failure is a clinical syndrome in which the heart cannot pump enough blood to meet the body's metabolic needs, or it can only do so by increasing filling pressures. There are many causes of heart failure, although ischemic heart disease is the leading cause. Other common causes include coronary artery disease, hypertension, and valvular heart disease. The pathophysiology of heart failure is very complex, although we can talk about four main mechanisms. These include the Frank-Starling mechanism, alterations in myocyte metabolism, myocardial hypertrophy, and the activation of neurohumoral systems. In heart failure, the mechanisms that may be adequate to maintain the overall performance of the heart become maladaptive when trying to sustain an adequate cardiac performance. The Frank-Starling curve shows that there's a relationship between a heart's preload and its output, specifically the stroke volume. As preload increases, the heart muscle is stretched, which leads to a stronger contraction and a greater stroke volume. However, in heart failure, the curve shifts downward because the heart has a decrease in contractility. So even with more preload, the contraction isn't strong enough, and that leads to a lower stroke volume. We can also see some changes in myocyte metabolism, which lead to myocardial remodeling. When there's a continuous wall stress, there are many changes in the structure of the myocyte. This can lead to hypertrophy or death. This eventually continues with remodeling of the tissue, usually the eccentric type, and after this, it becomes a cycle. There are more changes in wall stress, changes in myocyte metabolism, and then changes in cardiac tissue. This leads to a decreased cardiac output, which then activates a cascade of hemodynamic and neurohormonal changes. So, at first, the activation of the systems induces a number of changes in the heart, kidneys, and vessels that are designed to maintain cardiovascular homeostasis. However, with chronic activation, these responses result in hemodynamic stress and injure the heart even more. Okay, when we're talking about the activation of neurohumoral systems, we should visualize these two main columns. And what do they have in common? Well, they lead to the vasoconstriction or narrowing of blood vessels, and therefore to an increase of the afterload, blood pressure, and heart rate. So, if there's a decrease in cardiac output and blood pressure, then the baroreceptors activate, which cause the activation of afferent signals to the central nervous system, and therefore the activation of efferent pathways of the sympathetic nervous system. This causes an increase in catecholamines, which lead to vasoconstriction. On the other hand, a decrease in the perfusion of the kidneys leads to the activation of the renin-angiotensin-aldosterone system, which causes vasoconstriction and an increase of the afterload, blood pressure, and heart rate. We can classify heart failure depending on the cardiac phase that is affected. In systolic dysfunction, there's a decrease in cardiac output due to a decrease in contractility. Common causes include chronic ischemia and myocarditis. In diastolic dysfunction, there's a decrease in ventricular filling, normal myocardial relaxation, and an increase in left ventricular pressure. Common causes include coronary artery disease and pericardial disease. However, most patients have a combination of systolic and diastolic dysfunction. We can also classify heart failure depending on the side that is affected. And in left heart failure, we can see that there's a problem with the contractility of the left ventricle. Some common causes include left ventricular infarction and hypertension. In right heart failure, there's a problem with the right ventricle, And some common causes include cardiopulmonary and pulmonic and tricuspid valve stenosis. And they can also occur together. Okay, now we're gonna mix a couple of things. We're gonna talk about left heart failure, right heart failure, and the pathophysiology of its clinical manifestations. So buckle up and let's go. Okay, let's recap. Left heart failure is the result of ineffective left ventricular contractility. In this case, the ventricle weakens and doesn't eject all of the blood, which leads to a decrease in cardiac output, a decrease in renal blood flow, and the activation of neurohormonal systems. Since the left ventricle isn't working, blood backups into the pulmonary vein and creates a higher pressure in pulmonary capillaries, which lead to pulmonary congestion, dyspnea, and coughing. On the other hand, right heart failure is the result of ineffective right ventricular contractility, and in this case, the right ventricle weakens and doesn't eject all of the blood, which causes a decrease in cardiac output, a decrease in renal blood flow, and the activation of the renin-angiotensin-aldosterone system. Also, since the right ventricle weakens, blood backups into the systemic vein system. This causes an increase in venous pressure, which can show like edema in the legs, liver, and abdominal organs. If the pressure continues to increase, we can also see distension of the jugular veins and even cerebral edema. Alright, now how can we diagnose heart failure? The guidelines recommend the following: levels of B-type natriuretic peptide, urea, creatinine, electrolytes, fasting glucose and HbA1c, fasting lipids, and liver function test. Also an ECG, ATTE, chest radiography, complete blood cell count, thyroid function test, and iron studies. We also have the Framingham criteria, and this is a set of clinical guidelines that include major and minor signs and symptoms. In the major criteria, we can find paroxysmal nocturnal dyspnea, a weight loss of 4.5 kilograms in 5 days in response to treatment, neck vein distension, rales, acute pulmonary edema, hepatojugular reflux, S3 gallop, central venous pressure greater than 16 centimeters of water, circulation time greater than or equal to 25 seconds, radiographic cardiomegaly, pulmonary edema, visceral congestion, or cardiomegaly at autopsy. In the minor criteria, we can find nocturnal cough, dyspnea on ordinary exertion, a decrease in vital capacity by 1/3 the maximal value recorded, pleural effusion, tachycardia, hepatomegaly, and bilateral angle edema. We also have the New York Heart Association, and it's basically a classification that grades heart failure severity from class 1 to class 4. And it's based on how physical activity affects symptoms like fatigue, breathlessness, and palpitations. And here in class 1, we have no limitation of physical activity. In class 2, we have a slight limitation of physical activity and some symptoms like fatigue, palpitations, or dyspnea, and the person is comfortable at rest. In class 3, we have marked limitation of physical activity, and the person is still comfortable at rest but has symptoms like fatigue, palpitations, or dyspnea. And in class 4, we have the inability to carry on any physical activity without discomfort. We can also classify heart failure by left ventricular ejection fraction. If it's reduced, it's because we have less than or equal to 3%. If it's improved, it's because we have a follow-up of more than 3% in left ventricular ejection fraction. It can be considered mildly reduced if it's between 41 and 49%, and we also have evidence of increased filling pressures. We can also classify it as preserved if it's equal to or greater than 50%, and we also have evidence of increased filling pressures. When we talk about the treatment for heart failure, we can include non-pharmacologic and pharmacological strategies to limit and reverse its manifestations. We should include dietary and sodium and fluid restriction, physical activity as appropriate, and weight management. On the other hand, we can include diuretics, vasodilators, inotropic agents, anticoagulants, beta blockers, digoxin, and others. Now that you have so many options, you may be wondering what is the best treatment for my patient? When we talk about the acute treatment for heart failure, we should identify risk factors and comorbidities and, of course, treat them. On the other hand, we should also assess for congestion and hyperperfusion. I love this diagram because it classifies patients into four groups. They are either described as wet or dry, depending on their fluid status, and either cold or warm, depending on the assessment of their perfusion status. If we have a patient that has low congestion and its body's perfusion is not really compromised, then we can say that that person fits into the warm, dry group. In that case, we should opt titration of disease-modifying oral therapy if the patient has a reduced ejection fraction, and we should also treat comorbidities. On the other hand, if the patient has important signs of congestion and its body's perfusion is not compromised, then the patient fits into the warm-wet group. If we see signs of fluid redistribution, we can use vasodilators. If we see signs of fluid accumulation, we can use diuretics, and we can even consider renal replacement therapy in some cases. If the patient has low congestion but signs of hyperperfusion, then we should classify this presentation as cold-dry. Therefore, we can do a fluid challenge if the patient is fluid responsive or use inotropic agents. Finally, if the patient has both high congestion and hyperperfusion signs, then we can consider using a vasodilator if the systolic blood pressure is high enough, inotropic agents, vasopressors if there's refractory hypertension, diuretics only when the perfusion has been restored, and we can even consider mechanical circulatory support if the patient has shock signs that do not respond to drugs. And this diagram also helps to assess the prognosis of these patients. For example, warm and dry patients have a 6-month mortality rate of 11% as compared with 40% for the cold and wet profile. When we talk about the long-term treatment for heart failure, we should optimize diuretics. This is to maintain euvolemia, treat precipitating factors, and if the ejection fraction is preserved, then treat comorbidities. And on the other hand, if it's reduced, we should start and up-titrate disease-modifying oral therapy. The prognosis of heart failure depends on the evolution of heart disease. Following hospitalization, mortality is about 10.4% at 30 days, 22% at 1 year, and 42% at 5 years, despite advances in therapy. So, that's it. I really hope you find this video helpful, and see you in the next lesson.